Hi, I'm Matthew Dury. This is an update on COVID-19 evidence over the last couple of weeks. As always, the COVID-19 evidence.net.au website from the National COVID-19 Clinical Evidence Task Force summarises recent changes to the evidence. In the last couple of weeks, there have been recommendations on prone positioning and respiratory supports, particularly for children and adolescents. You can see there's an ongoing high rate of publication around COVID-19, particularly in the last 2 weeks. So the first study that I'd like to discuss is a study from the UK using data collected as part of the ICNAC study. This looks now at almost 60,000 hospital admissions with COVID-19. And they used these admissions to develop a mortality prediction score, which they call the 4C model. And this was a score based on parameters from 3 domains, so age, sex, and number of comorbidities, the patient's respiratory rate, saturation, and level of consciousness, and urea and CRP. And they combined these into a 21-point scale. And what they observed using data from patients admitted between February to April was that the score rose consistently as mortality rose, and this was the relationship that they plotted. And what they did was use that to then develop a prediction for mortality, and their score calculated an area under the receiver operating characteristic curve of 0.79 for predicting mortality. They used a cutoff of a score of 15 to predict mortality, and this gave a positive predictive value of 62%. And if the score was less than 3, the negative predictive value was 99%, so very good at predicting survival. However, one of the limiting factors with this score, as you can see, is that a large number or a large proportion of the patients will fall in that middle band where the mortality rises from less than 10% right up to around 50%. So predicting the outcome for those patients is more difficult. They also did a machine learning comparison as well, and so trained a machine learning model using data from these patients, and found that overall the prediction was similar, and so didn't seem to add additional benefit compared to the score that they'd derived. And importantly, the 4C score seemed to predict mortality better than other existing scores, such as CURB-65, and also some COVID-19 specific scoring systems as well. And when they plotted the observed to predicted mortality, they found that the relationship was quite close, and so the score in general was fairly good at predicting the outcome of patients. So the use for this tool, I think, is in the individual patient. If you are calculating their score and you are based in the UK, this would allow you to be able to estimate the risk of death for that patient. What's unknown is how this would compare to Australian patients and patients in other contexts where the mortality rate has been lower. There were a couple of other miscellaneous studies. So there was a study in neurocritical care from New York, which looked at 4,000 admissions to hospital with COVID-19 and reviewed for any evidence of intracerebral hemorrhage. And they found overall the risk of ICH was about 0.5%, with 19 patients out of just over 4,000 experiencing it. And in 17 of those 19 patients, they were anticoagulated prior to their hemorrhage. And in most cases, this was therapeutic or prophylactic anticoagulation administered for the purposes of reducing thromboembolic events from COVID-19. If intracerebral hemorrhage occurred, mortality unfortunately was very high at 85%. And what they found was that there were 3 patients who presented with ICH. 2 of those were anticoagulated, and it's likely that their ICH was not related to COVID-19. These are patients with, for example, a mechanical aortic valve. In one patient, patient 8 there, you can see that they had a hemorrhage fairly soon after admission. And in the other patients, you can see that the anticoagulation in red dots was started well before they experienced their hemorrhage, suggesting a possible causal relationship. But the take-homes for me from this was that overall, the rate of ICH, which would be one of the more feared complications from anticoagulating these patients, is very low. We know that the rate of venous thromboembolism in patients with COVID-19 is relatively high, and in some cohort studies, anticoagulation has been associated with better outcomes in general. So this would not change my recommendation to use prophylactic anticoagulation for these patients, and in fact, as the national guidelines recommend an increased dose of this. There was also a case report of a lung transplant of a patient that occurred whilst they were still PCR positive, and this has been of relevance at the Alfred because we've had several patients admitted on ECMO for prolonged periods of time who have persistently positive PCR. This was a 44-year-old woman from Austria who was admitted and placed onto ECMO at day 13. She, unfortunately, as you can see in that middle X-ray at day 52, still had profound respiratory failure with very little airspace visible on X-ray, and so she was listed for lung transplant. She then received the lung transplant at day 58 following a viral culture that was negative. But of note, she was still PCR positive at that time, and in fact remained PCR positive for another 10 days following surgery before finally returning negative results. She did have a second viral culture at day 7 following her transplant, which was also negative. And at histology, her lungs were grossly damaged with large amounts of necrosis and consolidation. And so it's likely that much of the PCR antigen that was being detected was simply dead virus. And it highlights the difficulties with using PCR to clear patients either for removal of contact precautions or for decision-making around transplant, as it may be that many of these patients will not achieve a PCR negative result for a very long time, especially if there is gross damage to their lungs after having had a high viral load. From a local interest point of view, John Rivers and Josh Eilert published a case report in the Medical Journal of Australia, which reported a woman who was 71 and presented with ST elevation, as well as a troponin rise, and fairly impressive echo features of Takotsubo. And they attributed her Takotsubo to anxiety related to the onset of social distancing and social isolation measures to reduce the transmission of COVID. From the point of view of treatments, there's been a lot of interest around the role of T cells in immunity. Antibody or a humoral immune response is well described, and in most cases, but not all, patients who've had COVID-19 develop a conversion and an antibody response. But there's some evidence that T cell immunity remains very important for recovery. There are some patients who don't seem to seroconvert and have a humoral response, but do have T cells that are specific for the SARS-CoV-2 virus, suggesting that there is an adaptive immune response that has occurred. And secondly, there's also evidence from the SARS-1 epidemic from 2003, where patients who were contracted the illness have a T cells present that are specific to the SARS-1 virus at 17 years later, well beyond their humoral response has waned and their antibodies levels have diminished. And thirdly, there's also some evidence that's found that patients who've never been exposed to SARS-CoV-2 have T cells that recognise certain epitopes on the virus, and these may have been from previous exposures with other coronaviruses which have some shared proteins, although not necessarily the spike protein, which is more specific to SARS-CoV-2 and SARS-CoV-1. But it does raise the question of whether previous coronavirus or other respiratory viral exposures might prime the immune system and may in part determine different outcomes in patients, and whether part of that is affected by age. So with all that in mind, there was a paper published in Nature Immunology which took 42 patients who'd had COVID-19 and did a detailed T-cell analysis looking at both the relative proportions of T-cells, CD4 counts and CD8 T-cells, as well as looking at different protein or antigen recognition domains on these T-cells. And they also found that patients who'd had a severe illness had a much more robust much more robust CD4 response compared to their CD8 killer T-cell response, which is interesting, and the significance for that is still a little bit unclear, and whether the relative populations of CD4 and CD8 determine disease. Now, the final other thing that's interesting in this is that we know that lymphopenia, so low leukocyte levels, or lymphocyte levels specifically, is associated with infection with SARS-CoV-2, and also may be related to severity or outcome. So with that in mind, a group from China published a randomized controlled trial of 200 patients who received GCSF, so a granulocyte colony stimulating factor, or standard of care alone. And these were patients who were admitted with COVID-19 pneumonia and also had lymphopenia with a lymphocyte count less than 0.8. The primary outcome was time to clinical improvement, and they also looked at secondary outcomes being the proportion of patients with ARDS, shock, and mortality. And they found that with regard to their primary outcome, there was a signal towards benefit from GCSF, with a higher proportion of patients achieving clinical improvement. And the median time to clinical improvement was 12 versus 13 days. And this was just outside clinical significance. However, more interesting was that patients who received GCSF had a lower chance of developing ARDS or shock at 2% versus 15%, so about 2 and 15 patients in each group respectively. And this was statistically significant, as was the chance of mortality at day 21, with 2% versus 10% experiencing death at day 21. And furthermore, when they looked at certain subpopulations, they found that patients who had a particularly low peripheral blood leukocyte count, or lymphocyte count, so those with a count less than 0.4, had a significant benefit from GCSF, as opposed to those who had a higher lymphocyte count. And patients who had a greater requirement for respiratory support, particularly high flow nasal oxygen or non-invasive ventilation, had a greater benefit from the GCSF, as did patients who were older. So this study looking at GCSF raises several questions. We know that dexamethasone, which is generally thought to mitigate an immune response and dampen down the immune response, seems to improve outcome. This, on the face of it, would seem to do the opposite with stimulating T-cell populations and immune response. And so it's still a little unclear why similar patient groups, patients who are more unwell, patients who are older, may benefit from both a pro-inflammatory and potentially anti-inflammatory therapy, and in which patients these should be given. And I think this is a very interesting study, and I think it will generate further work with GCSF and looking into patients who have lymphopenia as a separate population, perhaps. Now, there's a lot of interest in vaccines at the moment, and there's been much progress made in the last couple of weeks. This review from Nature reported on the proposed vaccines and the number of doses that the manufacturers are suggesting they will be able to produce by the end of 2021. And you can see that leading the way is the Oxford AstraZeneca group, and they believe they'll be able to produce nearly 3 billion vaccines. But there are other vaccines, several of which in many countries have made agreements to purchase multiple vaccines. If you look at the number of vaccine doses purchased by countries compared to their population, most countries, in fact, have been, or many countries, in fact, have been purchasing above more than they would need per capita, and I suspect that's hedging their bets in case one of the vaccines is delayed or less effective. At the time of publication of this article, Australia had agreed to purchase 30 million doses for itself, as well as New Zealand and the Pacific Islands. But subsequently, they've expanded their agreement to somewhere around 87 million doses of vaccine. And so this now puts Australia, New Zealand and the Pacific Islands together in one of the leading dose per capita purchases of the world. And the vaccine that they've agreed to buy is the Oxford and AstraZeneca vaccine, although there is also a separate University of Queensland vaccine program, which is in an earlier phase of development, and the government's also flagged interest in that. But unfortunately, the Oxford and AstraZeneca vaccine trial was placed on hold this week as a significant adverse event was reported. We don't actually know what the adverse event was, as that's not been disclosed, but we do know that the UK seems to have resumed its trials, whilst elsewhere in the world the trial is still on hold, and the impact on this on the Oxford AstraZeneca program and timeline, it remains a little uncertain. And we also have heard this week, or in the last few weeks, that that China has already reportedly vaccinated a significant proportion of people, up to potentially 100,000 people, and Russia, as we know, has proceeded with a vaccine program without having done phase 3 trials. And in a moment, I'll present the results from the phase 1 and 2 trials from the Russian vaccine. So there were 2 vaccines that published their phase 1-2 results. This one was interesting from a local point of view. It was published in the New England Journal of Medicine and was the Novavax, which uses a subunit vaccine. Essentially what they do is they use a soluble protein which is antigenic, and they use another substance to encourage it to assemble into a nanoparticle which resembles more closely the size and structure of a virus rather than free protein. And the argument is that this would generate a greater cellular response. And they found that using this antigen as well as a adjuvant called matrix M1 seemed to generate a fairly reliable immune response, and particularly 2 doses of the vaccine was required. And this, as I said, is interesting from a local perspective because this trial was performed in Australia, in Melbourne and Queensland, and in fact the Alfred Hospital Ethics Board approved the trial, even though it is an American-based development program. And then the other vaccine which was reported this week is the Russian vaccine, which has been labelled in the media the Sputnik 5 vaccine. And this was a combination adenoviral vaccine using 2 different strains of adenovirus, which had been modified to express antigenic proteins from the SARS-CoV-2 virus. They looked at 76 patients and found that the vaccine generated a reliable immune response, particularly in a lipophilized form, which is shown on the right there. And the immune response was similar to that found in patients who've recovered from COVID-19 and in their convalescent plasma. With both of these trials, the Novavax as well as the Russian vaccine, there were a reasonable rate of adverse events, most of which were mild or moderate, things like fever, pain, but no significant serious adverse events. And this is particularly relevant for the Russian vaccine program, as it was reported that they've proceeded with the vaccine program rather than performing phase 3 trials, which the other programs have been doing. And in fact, it was the Oxford AstraZeneca group who were in their phase 3 trial when they halted it this week. So that is the state of evidence for the last couple of weeks. As always, there's many new papers coming out each week, and I'll continue to review these. And there's also a review of the evidence for steroids in COVID-19, which I've summarised separately and is available. Thanks.